So the last talks between food, I guess, and you, that's me. So I want to talk to a trial that for me is connected to the right choice and also the right to choose. And it was actually like the first randomized trial I was very passively involved with when I rotated during my first year in general pediatrics on the bone marrow transplant unit. And that was the forum trial, and one of the questions being for the patients over 4 years of age, they would get for conditioning for their first bone marrow transplant in pediatric ALL, either total body irradiation or a chemotherapeutic conditioning, which in my center would have been busulfan based. And I met the patient there on the ward, Maria. She had acute lymphatic leukemia. Unfortunately, had a very early isolated bone marrow relapse, and now the plan was to go for allogeneic hematopoietic stem cell transplantation with a fully matched unrelated donor. And so the family was introduced to the possibility to take part in this trial, and she was in general ticking all the inclusion boxes. So she had an indication for the transplant. She was above the age of 4 years. There was no tumor predisposition syndrome, which would not be okay to go into the TBI arm, or be it a neurological disease or therapies beforehand that would not allow her to be randomized. And well, there was a discussion with the family, and I remember it well. They actually were not so interested in the survival data, which for me was surprising. And the attending talked about that, well, there is evidence out there, but a lot of it is retrospective. A lot of it is like mixed bag data, so combining very different types of patients. This one, for example, also adult and pediatric patients with not very strong conclusions, like this one saying probably TBI is a bit better, but then there's a lot of side effects in kids, so they didn't they didn't fully decide on it. And also some prospective trials, which this one, for example, showed that TBI is better, but this trial was just 40 patients, and in general, the survival wasn't very good. And after he had presented all that, they were mostly interested in the long-term side effects. And the patient herself, she was really worried about fertility. And well, of course, there's some data that TBI is really bad, but busulfan isn't great either. But probably the chemotherapeutic arm might be a bit better for that. And the parents were mostly worried about the neurocognitive outcome in her. And well, there is some prospective data even for it, for the IQ dropping, and but this. Like the IQ, you can see here, most of the patients still were able, for example, to lead an independent life afterwards. Nonetheless, probably that is a little bit less in chemotherapeutics, although obviously she wouldn't be in the most vulnerable age group, as this is the main reason why for the very young patients you would stay away from TBI completely. So they were thinking the study, might lead for her for a better life on the long term. But then she was randomized into the TBI arm. And the family really didn't want to go ahead with that and wanted us to go off protocol. And there were a lot of discussions. But in the end, they decided to stay on it. And actually, if they had gone off protocol, we would have only offered TBI to them, because that was our standard of care at that time point. And they went to a second center for a second opinion, but they didn't change it either. So, they decided to go through with us. And then the patient had the transplant. She didn't have a lot of problems. Day 180, she moved. She got the Hickman catheter out, moved on with her life, and only came back once a year. But then, about 4 years into the trial got stopped due to the fertility stopping rule, and the Independent Data Monitoring Committee, which I wasn't aware existed before that time point, actually recommended to have the trial stopped. And then the trial statisticians in Vienna, I suppose, were going through the data with the clinicians, and 3 months later this randomization arm of the trial was stopped for good. And as you can see here, the TBI proved to have a lot better overall survival for these patients. And after all, it might have been the better choice for her. And most of the deaths came from relapses in the chemotherapeutic arm. There was also a little bit more of treatment-related mortality, but that didn't reach a significant level. Nevertheless, of course, now they are starting to publish other data on the long-term side effects. That is still a mixed follow-up of their transplant study before that and the forum trial, but they can see that for some side effects, as expected, TBI is probably worse, and they just showed that at ASH last year, and well, I hope they will also publish on neurocognitive outcomes and other stuff like fertility, but of course, for that you need a lot longer a time frame to know about. And just another random paper about it, as mentioned before, TBI patients can have a lot of trouble, and you see it all listed down there, like, for example, secondary neoplasms in this group, 40%, cognitive impairment, 44%. However, 80% of these patients would still say they have a good quality of life, like as a positive notion about it. So Maria is actually alive and well. She's taller than me. She had a normal neurocognitive development, just ended secondary school, will go on to university. She does have endocrinological side effects. So she is on thyroid hormone. She spontaneously went into puberty, but the AMH is really low at a level where you can maybe still try to harvest oocytes, but she does not have a lot of time, to be fair. And just to sum up my conclusions from the trial, I think that TBI still has a big role for the conditioning regimen for pediatric ALL, and actually the outcome of 91% in 2 years is really good. I think that's a positive thing also to say to the parents. Then, of course, our patients should have a right to choose, but if, as a center, I guess you decide you are into a trial and you believe in the question and the way they interpreted the data, you shouldn't go off protocol without a very good reason. And for me, it was really good to learn that there is these safety measures and they actually work. And now when I read protocols, I look for, how if there's a stopping rule and how that is incorporated, because I think it's a good thing also to talk to the parents about when they are worried about it. And I think it's a real big, actually privilege that in pediatrics you have so many randomized, well-controlled, and also trials and compared to the adult world. And that's it from my side. And as you see, we have a lot of animals and they're even allowed on the ward. So. Yeah.
How many transplant people is in this room? Not much. Okay, any comments?
I was thinking you probably know a lot more about the story.
No. Yes, I can, because I think you're right. There were predefined time points at which our study statistician Ulrike Pötschke performed the analysis of this non-inferiority study, and these data have been shown to the DSMC, and they said we have to stop the trial because the difference was already at the very early time point of the trial significant, and it was not expected to change, and that's why it was stopped.
This is mandatory for all the prospective trials. And if you have bad luck, and then you have this, what you said before with the interferon study, if you have like 2 toxic deaths within the first 10 patients or so, then this might screw up the study.
And one other comment, I think you showed it, and it was important, the acute treatment-related mortality rate in the TBI arm, this is one of the most important findings of this trial, was very, very, very low, as you can see, 0.02. This was also surprising, of course, to us, that it was less than in the chemotherapy conditioning regimen arm.
I just have the complementing patient story, which was the patient had primary treatment at another center, so we were not directly involved in that, but the parents refused the TBI for the randomization, point blank, and refused further treatment. So then the physicians opted for the chemo-based conditioning, and the patient relapsed, came to our center for CAR-Ts, relapsed again, tried CAR-Ts again, but it didn't work, and then he was transplanted in the end, and now he's still in remission, but the parents have crucifying thoughts and are really putting themselves down. And it's a big topic for them that they, at the first attempt, refused the TBI. So how do you address that? What do you tell these families then?
I don't know. To be fair, this patient at the initial therapy went also off protocol because the parents didn't, so they had the anthracycline, they gave it differently because they didn't want to stay in the hospital for all of it. And I think that probably helped at that point, at this time around. And she relapsed so early, although she, wasn't a high-risk patient. So I think that helped us. And I don't know what to say to the parents. I mean, they couldn't have known, and they could have been lucky. I don't know. I mean, I don't have a good answer.
I have one question to you. Did I understand it correctly that if the patients or the family would have insisted on a chemo conditioning in your hospital, you would not have performed the transplant?
Oh yes, we would have, but usually we would not, we would offer our standard of care, and then if they say we pull the plug, then of course. Because that's what happened during the co-ALL trial in the first. They said they will not come back to the ward, so we did some of it in the ambulatory care setting with shorter infusion times. Mm-hmm.
Yeah, but you showed, and Fiona also commented on that, how hard it is to walk sometimes, because if you think too much advance and you don't live that long, if you miss some steps,